We have in Mary Kate Molman from Bi-State.
Thank you. For the record, Mary Kate Molman, Director of Vermont Public Policy at Bi-State Primary Care Association. And Chair, members of the committee, thank you for the opportunity to speak with you about Vermont's FQHCs and their current financial fragility and our FY26 appropriations request. Today, we're asking for an appropriation of $5 million in state funding to bring FQHC Medicaid rates more in line with the cost of providing care to Medicaid enrollees.
Was that
Oh, you don't,
I don't have slides.
You see that?
yeah, so you're gonna
5
have to
million.
like slow down and,
Yeah, sure.
yeah.
5 million general fund or 5 million?
General fund. Yeah, 5 million. Yep.
And that's for,
Bringing Medicaid, FQHC Medicaid rates closer to the cost of providing the care. So just as I was here last time, as a reminder, FQHCs provide care to 1 in 3 Vermonters, including 36% of Medicaid enrollees. The 11 health centers in Vermont have sites in every county in the state, and in many cases are the sole primary care provider in that community. They provide comprehensive primary and preventive care, including mental health, substance use disorder treatment, oral health, vision care, reproductive health, transportation, translation, and economic support services. They often bridge that last mile to reach those with the greatest barriers to care. However, this presence and these points of access are at risk. FQHCs have a different payment system than other primary care providers in the state. They should receive they do receive a single bundled Medicaid rate that it should reflect the average cost of a visit. They get the same rate whether that visit is a fairly straightforward wellness visit, or if it's a very complex, medically, socially complex chronic conditions that require multiple providers in the visit, they get that same rate. And this bundled rate is established by federal law. And it's different in that in other primary care, you may be able to bill for every additional service that is provided during that visit. Currently, Medicaid bundled rates for FQHCs will fall well below the cost of an average visit, as much as $60 to $80 per visit, in some cases even more. When compounded over the 54,000 Medicaid enrollees FQHCs serve annually, and this has been in the situation for many years, all of that deficit compounded has really contributed to the financial fragility of our FQHCs in the state. And I want to be clear that all FQHCs in Vermont are struggling financially. Some have fewer than 20 days cash on hand. Others are quickly drawing down from their cash reserves monthly, and they're really asking how long they can continue to do this. We've had 2 sites at 2 different organizations close this year. And if the current conditions persist, we have other members who are projecting out 20 more months of operations before they may have to close their doors.
When you said 2 sites have closed, what are those 2 sites?
There's the Bellow Falls site, which is North Star Health in southern Vermont, and then Lamoille Health Partners closed their Stowe clinic and consolidated their providers into their Morrisville site.
Leslie?
I don't know if you want questions now or you want to finish yours.
I'm almost done, but I'm also happy to take questions.
I mean, it's a federal designation, right?
Mhm.
And I'm trying to understand how this design ended up this way from the federal. I mean, Bernie Sanders, he really wanted it. It's here. Is the problems in other states as well? So is the program flawed and that the federal partner is underfunding it and therefore it's falling on the states? I'm confused.
So there's a lot of pieces to your question and a lot of parts to that answer. I would say it is both a state situation, and I would say it's state level across the country, because yes, a lot of FQHCs are struggling in terms of their rates not keeping up with the cost of care. That's not where Vermont is not alone in that. The other thing is on the federal side, the federal grants that FQHCs receive, which should not go towards Medicaid care. It should go towards regulatory compliance, supporting uninsured, underinsured, and all of the other enabling services that FQHCs provide. That has been flat funded for 10 years, which is
From the feds.
from the feds. I don't want to get into this right now because it's a very complex problem, but we also have another funding source, which is the 340B program savings. And that has been severely eroded over the last 5 years. But then going back to the Medicaid rates, we also have getting into Vermont's rates, we haven't really implemented the federal statute correctly in the 20 years or 23 years that it's been in place. So we are at a place right now with DEVA. The current DEVA leadership has been really helpful and supportive and trying to get us in a line, like making sure the rates are in line with federal law. But in that work, we are not seeing a significant increase in that rate, and no one is seeing an increase over their current rates without getting into the details, but.
Daisy, yes.
I just want to make sure I'm understanding that you, FQHCs, representing them, you are asking us to rescue a federal program. Is that, or is that?
No, we are asking the state to cover the cost of caring for state Medicaid enrollees.
That's all.
Yeah.
Okay, thank you.
Yeah.
I mean, is that what happened?
No, go
Is that what happened in North Star? North Star's in my community, so I'm pretty familiar with what happened there. And so what happened with North Star is the underfunding of Medicaid led to its closure? Is that what you're suggesting?
I think it's part. Yeah.
What's the other part?
I think workforce is also a factor. I think the rising costs. I think it's these other factors that have also contributed to financial fragility, the flat funding of the base grant, the erosion of 340B. But fundamentally, the Medicaid rates are not covering the cost of care for Medicaid enrollees.
So do you think that if we did this, that it would save FQHCs, that we wouldn't have more losses? Or is that enough to sustain the FQHCs, or is the flat funding it's too embedded, it's structurally a problem, and why invest more money in this failing model? Financially failing model. I understand that you're doing great work for people in primary care, et cetera.
I mean, we are working on multiple fronts to address this. Why my ask here today is to focus on the Medicaid portion of it. We are also working at the federal level with a lot of the other primary care associations in every other state and our national association on the federal. We're also working on the 340B. Like, our health centers are doing what they can. I mean, they have been very creative and very, trying to figure out how to make operations work, but we're kind of coming up to the end of what is possible for being creative to make things work. Again, my request here is to focus on making sure Medicaid is covering their portion of the cost of Medicaid enrollees, and that's 36% of Medicaid.
What is, I'm sorry?
We serve 36% of Medicaid enrollees.
Daisy?
I kind of share Leslie's concern about the fragility of the federal model, and I've been watching it for the last decade and watching the level funding and being aware of just the age of the model and knowing that it's ready for another iteration, but also recognizing I go to my local FQHC. I adore the practice, but nevertheless, I want to see it continue and grow. And I'm wondering, one opportunity that I recognize for that is for some of our FQHCs to complement the incoming CCBHCs that Vermont is growing. And I understood that there was an early reluctance to do that or lack of connection happening, but can you update us if there is more partnering or DCO MOUs happening between the new CCBHCs and our existing FQHCs?
Yeah, that's a really good question. And that's something that we have been working with our members to make sure they are aware of the development of this model and their role in this model. FQHCs are outlined as one of the required partners for CCBHCs. We have been in close contact with Vermont Care Partners, trying to, on an association level, stay in touch. And I know a lot of our FQHCs work closely with their community designated agency. I think, to be frank, some relationships are stronger than others, but it's something, I don't have the most recent information. It's something actually I've been thinking about trying to loop back on and make sure, understanding where each of our members are in having that communication. But we have at multiple points by state has reached out to Vermont Care Partners and tried to make sure that at an association level, we are collaborating, as well as at an organizational, at the community level, collaboration.
Such a great opportunity because
Mhm.
he designated both, right? And they get a better reimbursement rate with the.
Say that again? Sorry.
You can be designated as
Yes.
both at the same time.
Yes.
And just, I strongly support looking into that in terms of a fiscal benefit.
Yeah, and I would say our FQHCs and the way that we've approached it, we have allowed the designated agencies to really step forward as that main CCBHC designation, knowing that that's where a lot of that expertise, especially for some of the more high and acute care that's provided in the designated agencies, and then our members coming in that supporting, collaborating role. We have not pushed any of our members to try to pursue that designation in and of themselves, because we have wanted to partner as opposed to lead in that space.
All right. Two questions. The 5 million is separate from, I know your organization was listed with Jessa Barnard's testimony. So 5 million is separate from the 10.8 million that they requested for lost Medicare payment for the blueprint and BCMHs and all that.
Yes, it is separate, and this is when I mentioned like the 20-month run out, that is a calculation before we really knew that the OneCare funding, which is ending in 2025, and the AHEAD model was going to, and the signing of the AHEAD model for cohort 2 left us in this gap year. So that calculation excludes the 4.7 in the OneCare population health management funding, as well as the Blueprint Medicare funding.
So the 5 million would cover bringing the Medicaid rates closer to actual cost?
Yes.
Okay. And are there multiple Medicaid rates for different primary care services, or can you give me give us an idea of what the current Medicaid rate is and what rate would be the number of percentage that would cover costs? And you can do it later if you want.
So I'm thinking if I can just throw out some average. So the idea is that each health center should have its own rate based on its own cost experience. So if you have a health center with a lot of rural locations, so for example, Northern Counties has a location in Island Pond, that's really the only primary care available, but it's also because you're so rural, there's a lot more overhead associated with that. So it would be a higher cost location. We want the federal law wants the organization's rate to be reflective of the differential costs that each organization experiences. So while they receive the same rate within an organization, whether it's a well visit or, like we heard one health center provider describe, they had someone in the clinic all day detoxing and providing multiple care to get the person onto medicated assisted treatment. right, the detox and then the onboarding of medication treatment and then getting them into care, that was the same rate
As a sore throat.
as a sore throat.
Yes. That's the
Um,
problem.
And the idea is that the rate is supposed to be a prospectively determined average cost of care, average visit. So and then it's supposed to be, get into the mechanics of it, gets complicated, but it's supposed to be inflated annually. And then you're supposed to be able to adjust it based on any changes to the organization, like adding services, or if they open a clinic that has like a much older population that require a lot of resources, that's another way that you can adjust the rate. But so for the most part, the rate should be reflective of what it costs to provide the care.
For that center.
Yeah,
Thank you.
you're welcome.
So every year in the BAA, there's kind of the adjustment because it's federally mandated that is this the same rate that we're talking about here for the 5 million raising the rate? And is it because of this 10, 15, 20-year negotiation that's been, however long you said it had been going on? Is it because that hasn't been, or is it a different rate? What do we see in the BAA?
That is the Medicare Economic Index inflationary factor.
Okay.
That is applied annually to FQHC rates. That is one of the things called for in the federal statute that lays out how a FQHC rate can be adjusted. It's either that MEI, Medicaid Economic Index, or adjustment for changes in the scope of services. The problem is the underlying rate that FQHCs have been receiving and to which that formula has been applied has been underfunded, has not met the cost of care. And there's a whole long history. We're talking about 20 years of history of FQHCs and DVA going back and forth. And I do want to call out that the current leadership at DVA they are knowledgeable of FQHCs, and I feel like we have some movement going forward in trying to make sure that QHCs are able to stay stable financially and meet the needs of the community. But I think part of it is getting that legislative appropriations to bring that the rate up to where it needs to be. And then we can continue to move forward on these more incremental adjustments.
Okay. And the last question was, and Leslie, I do see you, you talked about the example of Island Pond and whether or not the FQHCs is a failed funding model, federal funding model, and a failed federal program. If, let's say that practice in Island Pond was not an FQHC, because you talked about how they still have the high administration costs. Would that practice be able to sustain themselves? And would they be more efficient if they were not federally designated as an FQHC, if they were just an ordinary practice providing the same services under a different model, or essentially maybe let's just say fee for service
Or a head, maybe.
or a head?
Payment, whatever.
Would they be able to be more efficient if they were not an FQHC and still deliver the same services?
I can't speak to that. I'd have to look at, what it's a really good question and it's an interesting one. I don't feel I have enough information to respond to that. I think some of the federal resources allow clinics to operate in these more rural areas. I don't know if an independent could also provide that level of service and meet that higher overhead.
Just wondering, because it's along the same lines of what I was asking Jessa, which is, are we relying on funding to fund the administration of the programs to receive the funding? Are we spending the money that we're receiving just on administration
Mhm.
to get the money. And if we weren't, if we weren't, chasing dollars, could we rely on providing the same services without the money that we're chasing, that we're spending all this money to chase?
No, it's a fair question. And actually, if you wouldn't mind, Madam Chair, I'd love to punt to my colleagues who will be coming in tomorrow, who can really speak more to that operational,
Yeah.
what they face as a reality in terms of providing care in those more remote areas.
Great. I'm looking forward to having them in tomorrow.
Thank you.
Leslie.
Yeah, you're just going where I was going. If it's a failed model, what alternative models are there available to us for $5 million? Or God knows what else we're paying, to have access in other places. So that's what I'm interested. I know that's not that's not for you. But I think it's for the committee to start thinking about, or if we could take testimony on what alternatives are available, to continue to provide care in rural areas we could start with. That is a better model. And that's what I'm curious about.
Could I take $5 million
Yeah,
and pay 5 primary care providers
Right.
$1 million a year to just go practice medicine?
Yeah.
I'm sorry.
Can I
Daisy.
Can I just say, I would need a lot of convincing to say that the FQHCs are a field model.
Yeah, I'm having trouble with that.
Yeah, and so I think there's a lot
No,
that.
no,
that
not a
is
failed
going
model,
on.
failed funding model.
yeah.
I
I think that's an important
Okay.
distinction.
Yes.
Really important.
Failed funding model.
Okay, but they
Not a-
still do receive an enhanced federal.
But it's not
That's
working.
And, okay, hold on.
Yeah, sorry.
There is a lot of other stuff happening in our system that we are addressing that touches on every single provider in our system that we're working on. So I think before we say that the funding of FQHCs is broken, I think we have to step back and look at the work we're doing on the con, that we're doing on provider burden, et cetera.
If I could make one point kind of speaking to that, the Congressional Budget Office last year for the first time rated the FQHC program. And in their report out on a bill, they called out that increased funding in the FQHC program would result in lower overall costs by providing high quality, low cost care and avoiding those more expensive emergency department visits and inpatient stays. Our national association has also done some looking nationally at each state, and they've provided results for each state. They estimate that Vermont's federally qualified health center saves Medicaid 24% or $128 million.
I'm not sure who you're referring to. Who? The state of Vermont, the country, who?
So our national association did this study nationally, looked at each state, and they estimated that the impact of Vermont's federally qualified health center
Mhm.
program
Mhm.
saves Vermont Medicaid $128 million.
I'd like to hear from Vermont Medicaid and see if that makes sense for them too.
And I want to be very clear. I said that FQHCs are a failed
Funding.
funding model. And when you say that you've been level funded by the federal government for
Mhm.
how many years?
10.
10 years, I think we can say that that's a failed funding model. Not saying that FQHCs are a failed model.
Mhm.
Mhm.
Okay, Mara.
I just want to support that, and I don't want, I think FQHC as a model is really successful, and if.
A care model, a care model.
If it was supported appropriately, it could be even more successful, so I just want to get another voice out there, so in support of FQHC.
But the question is, whose job is it to support the failed funding model? That's my question.
I think that's a great question. Oh, Topper.
Got the answer.
What is it? Oh, well, go for
The
your.
federal government is supposed to do it.
I think so, and it's not likely.
I mean, it's in the law.
That doesn't, I mean, we're not.
Laws don't seem to matter
Yeah,
these
these
days.
days we have a different amount. That's a different.
Sorry, it just popped out.
Thank you, and I'm happy to answer any additional questions if you guys have them after I finish my testimony. Thank you.
Thank you for putting up with me.
Yes. It's a pleasure.
Next up, Amy from Vermont Care Partners. It's good to see you. For the record, Amy Johnson, Vermont Care Partners. Thanks for having me today. I know you've had us in this committee a lot this session already, which we greatly appreciate being able to talk about our work. So I won't eat up too much of your time, and I do know that we're a bit behind. So I'll just kind of focus on what our ask is and our why, and allow for questions, and we'll go from there. So you already know this, so let's talk about finances and the ask. I'm just gonna start with the ask in case I run out of time. I am long-winded. So we are level funded in the governor's budget for this for fiscal year 26. As you know, when we think about the cost of care and we talk about inflation, we know that level funding is a cut. And so for us, we did robust analysis with the CFOs of all of the participating agencies for Vermont Care Partners. And so what we came up with was a 6.2 Medicaid rate increase to provide essential services to Vermonters. You already know a lot about our services. I'm more than happy to answer more questions about them, but these are services that are available to Vermonters that we provide on behalf of the state. So our ask is $13.95 million, and that's general fund. That's to support all 16 agencies. I will say if Nolan was in here, because he's the smart finance guy, that number looks a little bit different when we add in the other two agencies that are not part of Vermont Care Partners, and we do get increases. They are included as well, as they should be. So that number will look a little bit higher, but that is the general fund need. So you can see the analysis that was done. We looked at, the BLS statistics around salary increases across the country. Health insurance, obviously, that gets talked about a lot in this committee. So you know that those increases are very high. What are fringe, other operating costs, and inflationary increases. So once we kind of crunch all those numbers, this is what we need to keep the lights on. So you hear that a lot when the agency comes in and talks about their budget. We also need to keep the lights on to be able to provide essential services. Speaking of laws, so this is already in statute. That's fun. Payment rates, and I will just kind of note the agency shall look at rates and adjust rates as necessary. And you can see number 2 really speaks to that inflationary piece. So this is codified in law, and this isn't something that we see in practice. Now, I will say that we have gotten rate increases over the course of several past fiscal years. However, those have come most notably from the legislature. We are very appreciative of that, but that is not coming from the governor's budget. So just wanting to note that and highlight that this is in statute, and I do know that H13 is also moving through the legislature this session, which is important and is connected to this as well. This, I had our CFOs make this for me. There's a lot going on in this slide. I put a key just in case you needed it, but this goes back to fiscal year 2008. That's assuming that we were in a good place financially in 2008. Arguably we weren't, but this is as far back as I could go. It looks at what the CPI was for that year
what our increases were from DMH and Dale. You'll see DSU in one of the columns, that's the Department of Substance Use. That sits over in House Human Services. You oversee the DMH budget. So you can see the increases that we got compared to the CPI and kind of the variance, so where we land. So at some point in FY14, we look a little bit better, we're not behind. But ultimately, if you look at the cumulative, we are pretty significantly behind. And so that poses a variety of challenges for our agencies in terms of providing essential services. And also as it relates to the workforce. We know workforce is a big issue, but it's very challenging to, I would say recruitment and retention are two separate things, but if you're looking at retention or recruitment of staff, it's very hard to recruit people when you say, well, we can hire you at this salary, which might not meet your needs, and also we can't guarantee you an inflationary increase every year. And I will say, as somebody who's hired lots of people over my years at the DA, the first question that people ask is how much the position pays. They also ask, do you get increases every year? And what I would have to say to people is it's not a guarantee. They often come from the legislature and we have to advocate for them. I think that's important to note. So folks often say, well, if we give you a 3% increase, why doesn't all 3% of that go directly to staff? That's a great question. We would love to get as much funding into staff's pocket as we can. However, here are the other budget pressures that we have to account for to keep the lights on. The thing that I would note is if we're not supporting the health care is a big piece of the fringe benefit for staff, that if we're not supporting that increase, we might be able to give staff more money in their pocket, but then they're paying more in their health insurance. So it really ends up being either a wash or still a loss. So there's other non-staffing budgetary pressures that we need to account for. Again, the CFOs did the analysis and that 13.95 million accounts for this as well. So you've heard from a lot of folks in the industry talking about challenges with finances. So this is our cash on hand. I decided not to compare it across anybody else, just to really focus on this is an aggregate. So this is all of the agencies. Some are doing better, some are doing worse, but in aggregate, these are the days of cash on hand that we have. And you can see starting from fiscal year 17, things go a little better in fiscal year 21, but as you can see in fiscal year 24, 63 days of cash on hand. We do have folks that have dipped into reserves. We do have folks that, take out line of credit, or have had to consider taking out lines of credit to cover payroll. These are dire straits for organizations. And again, what I will say is, and what I know you've heard in committee, and I've heard it too, some organizations have healthier budgets than others. I would argue that everybody is struggling right now, but even if you have a healthy budget, to be able to support the people that are at the agency that are doing the work with vulnerable populations, funding needs to be infused into that bottom line to be able to give increases to people. We can't just keep it at zero and say, well, it's healthy, so you shouldn't get anything, because then it becomes unhealthy, right?
Woody, did you have a question on the last slide?
I did.
You want me to go back?
You can if you'd like. The health insurance.
Yeah.
That is separate. It's not part of a program. Is that correct?
Yeah, the agencies each have their own health insurance plan that they offer.
And I know you're not a state agency. You're not state agencies. But I wonder if you were part of a state health insurance program, would it be cheaper for your designated agents?
I would say that each agency looks at what is going to be the best benefit to staff and the most cost supportive. I do know that we have people in the room who do this work and figure this out for their agencies if they want to chime in, but yeah.
Are most self-funded? Are most of them self-funded or are they just purchasing on the market?
Sandy, do you know?
Most are either self-funded or captive.
Okay.
That's the cap.
I have a question. I don't know if you can see my hand.
Oh, sorry, I did not see that, Brian.
I-
Thank you. Go
I
ahead.
figured because when the screen's up, you often you can't. I have a question that you may not be able to answer today, but I wanted to ask. First, I want to say I support the raise. So it's not about the raise, but it's about another related cost saving thing that we've been hearing about, reference-based pricing. Or do any of the designated agencies currently use like negotiate for pricing with their insurance providers? And if not, is that something you could check in with the designated agencies about if they'd be interested in looking into that if we move in that direction?
I'm gonna go back to Sandy if you happen to know. If not, I can get information. Thanks, Brian.
On that slide that you did with the benefits in healthcare and.
This one?
Yeah. What does other insurances cover?
Other insurances, I have it back here. So the general liability, auto, property insurance, that's other. Do you see it up there? What, the second to last bullet? I can get you more information. So these investments do matter. So one of the things that we heard in committee was hundreds of millions of dollars have been invested and it hasn't made any changes. I would argue that. This is a fun one. There's a lot going on here. But you can see, so the gray line at the bottom is the increases that we received from the legislature since 2018. You'll see the yellow, blue, and green. We started pulling apart vacancy and turnover separately across developmental services, mental health and substance use and admin. So we started doing that in fiscal year 21. So that's why those lines are shortened. But you can see the overall vacancy and the overall turnover, and you can see that there are shifts in a positive direction connected to the rate increases that we're receiving. Here's what I will say, and something that I think was interesting that came out of the Oliver Wyman report was robust investment or aggressive. I think the language we might have used was aggressive investment is needed to turn the curve. When we're thinking about a 6,000 person network, to be able to turn that ship, it takes a lot. And so if we're asking for 6% and we get 3%, we're so appreciative. However, it's not going to show a huge curve turn because what we need versus what we're getting, there's still that gap in between. So you'll see things improve, but you're not going to see this like huge turn of curve because we're still under invested in. And so that's still a challenge. And I would also go back to the point that if I'm somebody who's thinking about entering this industry and I see that I'm not going to be guaranteed increases in this profession, I might not even decide to step through the door. Like what value do we have on these services? I would say these are incredibly valuable. They're incredibly important to our state. And how do we demonstrate that? And when somebody sees that, this is an industry where they're, not necessarily getting paid the rates they should be getting paid and that they can't be guaranteed increases, that impacts somebody's ability to stay. And it also impacts somebody's ability to choose to enter the field. And so again, I do appreciate that the legislature has shown that value, and that's important. And that does matter. And I can say that as somebody who worked at the agency for 10 years, that getting those increases, and even though it was still hard to make ends meet, it mattered to me that somebody valued the work that I did. You've heard this before, and I've had this slide before, but wage is the top reason that people leave. people need to be able to meet their needs. These are really hard jobs working with vulnerable people. And when you can't meet your own needs on top of the stress of the job, that's really challenging. So people do leave for higher pay. Burnout, we know these are hard jobs and administrative burden. We work really closely with the Department of Mental Health and other departments, and we have done a lot of work and they've been really helpful in helping us to kind of crack that nut. Again, we've heard like some agencies are doing better with recruitment and retention and some agencies aren't. And I just want to point out that there are other variables that are impacting people's ability to recruit and retain staff. Some places are food deserts, some places are childcare deserts, healthcare deserts, and then housing is just a huge layer on top of everything. If you can't find housing, you're not going to be able to move to that area to be able to take that job, or maybe you have to move out because housing is getting too expensive. And then obviously we have a lot of competition with the state, with schools, with a variety of individual or organizations and entities that can pay a lot higher for the work that we do. And then this is just kind of the impact of staffing shortages. So obviously we want to keep people housed. Our supports help to keep people housed. If we don't have the people to do that, it's hard to keep people housed. Increased ED use, that's gotten better as we've seen more people kind of fill those vacancies. Longer wait times. So, this is all stuff that I know we've brought to you before, but there are consequences to, having underfunding in the system, and it has kind of a ripple effect on society. So yeah, I'm gonna put some here they are, I had to, because, and I reworked it a little, but what I want to say is like what you feed is what you grow. And right now, and I said, this is what is coming, but I honestly think this is kind of where we are. I want to be really clear in this committee. Our crisis continuum is incredibly important, and we are always going to need it, just like we always need 911. There's always going to be things that happen. We can do the preventative work, but there are going to be situations where we need, in the crisis beds, we need 988, we need enhanced mobile crisis. We need all of that. But the thing is, as we hollow out the home and community-based system, we grow the high-end supports, which is much more expensive. And we're not going to be able to get out of that cycle. Like if we don't, yes, we need to put more money there, but as we invest upstream, we will have to invest less money downstream. And I think this committee really understands that. But I would say this is probably where we are right now. We're seeing a lot of investments in high-end supports, again, very critical, but we need to also do that critical prevention and community-based work. And you can see all that great stuff at the bottom just getting kind of smaller as we have less funding to be able to do it. This would be the ideal, we still need the high-end supports that we can kind of see and everybody talks about, but we want that really robust base at the bottom.
Brian, I think Brian has a question.
Yeah.
I see your hand up.
I do. I put it up, but I was waiting to not interrupt, but I appreciate you calling on me. The question is, I don't remember what the recommended budget from the governor suggested for funding the DAs, and I was wondering if someone could remind me. You're asking for 6.2%, right?
Yeah, there's not an increase for us in the governor's proposed budget for
It's
fiscal year
0%.
0.
So that's a cut. Okay. I just,
Level
yeah,
fund.
and I do want to say, as a person who works at a designated agency, that it's harder for me to, I'm a social worker who's worked for 30 years. Wait, no, 27 years in Vermont. It's harder for me to afford to live now than it was 10 years ago, 15 years ago. And the acuity that I'm seeing as a crisis worker is like another level. And I don't know, and I just wanted to say that, you mentioned that, but it is incredibly hard to continue doing the work right now. So it actually being reminded of that is hurting me, to just sit here and take that in. That I'm being asked by the governor to go to work and take a pay cut while he gets a 6.4% raise.
Yeah. And I will say, I appreciate that, Brian, and I will say, you know, we know that the state workers are part of the Pay Act and they get an increase, and we're certainly not arguing against that. I think everybody needs to be able to afford to live, and, you know, accounting for inflation is really important. So we think about the staff that we partner with at the state, and we support that. And we're saying that we're doing this work and that we need this to be supported in that too. I'm not going to go into detail, but we want to be held accountable. I want to make sure that people understand that we have a designation process for providers as well. The CCBHC is coming and there'll be certification. We have centers of excellence. And then there's a lot of data that we provide to the state, a lot of reports. We have performance measures. We're held accountable. We want to be held accountable. We're not saying, give us some money and we don't have anything to show for it. That we just want to, and this is a non-exhaustive list. I just want to just remind folks that we do have contracts, we do have provider agreements, we adhere to you know, different processes and performance measures and outcomes, and so we are held accountable. We want to be held accountable, and that's important to us. You've already seen this, and I have the QR code so you can look at our impact report, but we do a lot of good work across the state. And this is just showing kind of that how well is anybody better off, talking about the supports and services that we offer. I want to, and I've had this slide before, so it's not that I'm buzzing through it because it's not important, but I just kind of want to end on this quote from somebody from the DA. These are difficult jobs requiring patience, skill, dedication, and we hold a lot of responsibility. We're asked to go into different situations and support people during some of the most intense periods of their life. Why isn't that valued more? We're making Vermont better, healthier. I'm a solo parent and have moved into a leadership position. It's still difficult to make ends meet. I love my job and don't want to leave, but what are the options here? As the cost of everything goes up and we continue to be level funded, I feel like my hand is forced. It's difficult to support families struggling while I'm struggling myself. That person doesn't work at that DA anymore, just so people know. But I think the data is really important, but the stories are really important too. This is what I heard from so many people that I love it here. I love the job. I love the culture. I cannot afford to make ends meet. And I know I'm talking a lot about the people who are working, but that impacts all the people that are being supported. That's so important. We have vulnerable Vermonters who need our help. And we need people to be able to provide that help. And when they leave and it's a revolving door, that continuity of care, it impacts their treatment plans, it impacts their goals. Those relationships are really important. So keeping high quality staff in place is just so critical to the health outcomes of those folks that we support. I know I'm eating into Sandy's time, so I would love to just keep talking to you in the committee forever, but that's the information. Got our ask. I know I'm out of time, but any questions, and I can always.
I think we have Leslie and then Daisy. So Leslie, you want to go ahead?
So I'm thinking about funding models, right? Because we can talk about funding models. And if I remember right, I look back at your slides, I didn't see your payer mix. But the payer mix for the DAs, pretty skewed towards Medicaid.
Yes.
Which we know is underfunded. So I'm thinking this is another failed structural problem. We know the people at DMH are all getting that built-in raise, but the DAs don't. So I'm really concerned. I don't know the answer, obviously. I don't know why the DA system got, this sort of set up the way it did as outside organization, but it feels like it's a failed funding model again. And it bothers me that because of the payer mix and people who have access to insurance and have agency, they go outside the VA system frequently, whereas the DA system is being starved. I'm having trouble with that. I'm just saying it's a feeling, and I don't know what to do with that. It really bothers me.
I will say that there's some reform. We hit CCBHC is something that we're really looking forward to see how that plays out. That's really looking at. It's a really great model, and it's also looking at, being paid the true cost of care. I think that's really important. And if that's the way that that is the way it's designed, and if that's the way that it ends up looking, that's going to be really helpful. So there are wonderful people doing smart things in the state to kind of fix some of this, but that's, you know, that's happening down the road, but like, this is where we are right
Yeah,
now,
that's,
right?
yeah, for
Yeah.
sure. But that's depending on, but that's federal, like.
Yeah, there's enhanced federal, well,
So
I
once
have
again,
Nicole here
not-
who
we
knows a
don't know
lot
what
more
we can
about it than I
depend
do,
on.
but.
Yeah.
And with the level funding that came to the legislature from the governor and from the secretary of AHS, are DAs able to give staff raises?
I would say it looks different across all the different agencies, but what I will say is it's really challenging. Again, I know Sandy's sitting here, so she could probably speak to that when she's sitting here, but I know that agencies will do what they can to be able to give people things, but we've definitely had years where we've not gotten increases because there's just not the funding available. And so you're really thinking like, are you gonna cut things to be able to, you know, what do you cut to be able to like make your bottom line meet? Make your bottom line. So I think like some agencies might be able to give something and others can't if they get nothing.
Depending on what they supplement their budget with in addition to the state funds.
But I would say by and large, it would be very challenging. But I think there are people that are committed to trying to figure it out, but I know that there might be, you know, one or two agencies that have talked about it or been able to do it in the past, but ultimately, even if you have a healthy budget, like I said, if you're not infusing funds into that to support what's happening with inflation, it's really challenging. You're just gonna end up bleeding yourself out.
Do executives, leadership at designated agencies, do they get enough opportunity funded by the state, supported by the state for business growth, training?
That I would have to ask. I don't want to make any assumptions, so I could get that information for
Or do
you.
you think that would be helpful? It'd be good to hear back from you if you think that would be helpful, because what it sounds like is they're getting level funded, but I want to make sure that if that's happening, that those leaders at those organizations are well equipped to find other pathways of funding. Thank you.
Topper?
My understanding of designated agencies. I don't know if all of them do this or not, but they fundraise. And they have money in the bank.
I don't
I'm
think,
wondering how much money each one of these has. Is it enough to weather the coming year?
I want to say no. I know that not all of the agencies are able to fundraise or have like a team of people that do that. So I wouldn't say that all agencies are doing that. I would say that some are and some are able to do it. And thinking about like regionally where you're at and like who's available to tap into fundraise, like that's going to look different across the state. We know some areas just are leaner in terms of, you know, folks that are able to give. So I think it looks different across all the agencies. I know not all the agencies have the capacity or the teams to be able to do that. And the financials on that, I would have to get back to you on like what that dollar amount looks like, but I would imagine that that is not something that would be able to sustain the agencies and the work that they're doing and the staff that they have without some kind of funding from some kind of rate increase or inflationary increase.
And the other thing, I'd like to apologize for asking that question that I asked you before about insurance. I didn't read the thing right.
That's no apologies necessary.
I don't like to ask questions that I know I should have the answer to.
All right, thank you. Thank you for coming in. And so we asked Howard Center to come in. And there was when Department of Mental Health was giving their budget presentation, last week, I think they had some community outreach teams that they were recommending be cut. So I thought we would hear from the designated agency to give their perspective on this. So welcome.
Thank you. I'm Sandy McGuire, CEO at the Howard Center, and we appreciate the committee's invitation to come in and respond to the proposed cuts targeted specifically to the Howard Center in the governor's budget. There are 3 areas of proposed cuts. One is to our community outreach program. One is to an embedded position in a primary care office. And related to that same funding is additional funding that supports 5 clinicians in our crisis program. And so we're going to give an overview of the services in those areas that we think might be helpful. We're going to do that briefly so that we have time to answer questions and find out what might be helpful to the committee. Also, just to set the stage a little bit, as I hear a lot of questions in the prior testimony about sort of overall how are agencies faring, what do things look like? And as we look at the days of cash that Amy shared, that is an average, Howard Center's days of cash today are 13. We average between 20 and 30 days of cash overall. And so we are dangerously close to that line. We do have a line of credit. We have not hit it. We are glad we have not hit it. And it is important that it is there. Our cash can be a little seasonal depending on a lot of factors. The fall is typically when it's lowest. This past fall, we had a week that we got down to 6 days. And so it doesn't take long. We're in our 3rd year of a financial deficit from our program operations that we are working as hard as we can to close. We currently get the 2nd lowest per member per month payment for our mental health services. And so as we work and partner with the state, how do we look at new funding streams? How do we look at CCBHC? How do we look at about how do we turn this corner and shore things up? Also trying to figure out how do we bridge the time until we get there. And so today's conversation, and as we look at these cuts and these funding in the big picture of things, it might not feel like a lot of money when we're talking about $600,000. And when we're trying to put everything we can together, and that's almost 2 days of cash for us, it's really important. So I just wanted to provide that backdrop overall. And so, yes.
So does that include the money outside of the money that you get from the state or wherever you get it? I'm talking, what I was looking for is the money that you have in the bank that is being invested in. It's
All of our cash reserves.
So it's all the cash reserves and everything. Okay.
So I will turn it over to Beth to do an overview of the areas that were addressed in the governor's budget.
Hi, thank you. My name is Beth Holden. I'm Chief Client Services Officer at Howard Center. 32 years in, started as a crisis clinician, worked with kids, worked with adults. So I know the services as a clinician and as a supervisor and as an administrator. So thank you for this time. Nothing gives me more joy than talking about what we do and how we do it. I'm hoping to provide some clarification today of some of the questions that have come up, particularly the Milton Family Practice position, first call, community outreach, and Vermont's enhanced mobile crisis. And we know we're complex and we know services are complex. So thanks again for an opportunity to clarify and answer some questions on how those programs may overlap or not. To start with the Milton Family Practice Collaborative, EPSDT started probably about 20 years ago. We have had an embedded clinician in that primary care office all that time. It's the same one. She is well connected within the community as well as in that office. I think one of the clarifications I'd like to make today is there was an idea that perhaps mobile crisis could take that work over, commenting on a duplication of services. I would challenge that thinking that I don't believe it's apples and oranges. I believe it is apples and oranges. The clinician does have a caseload of any given time of 11 to 20, and that is a caseload. So those are regular children and families that she follows. We also do work with people who are not part of the Howard Center system. They do not want to be opened. They do not want to be diagnosed. They do not want to be part of it. They are willing to meet with our clinician through the primary care practice, but they have that choice. They don't have to become our client.
I'm a little confused. we're talking about the position embedded in primary care,
Correct.
which I think is Milton Family.
I'm sorry, yes, those are
Practice.
two of the same.
And you said that it would be backfilled with mobile crisis. I think my question, and I don't think that DMH was indicating that they would fill that position with mobile crisis. I think that was the community outreach teams that they were thinking of. But my question is, why is that position, and you may not know this because I don't believe you staff the community health teams. Why is that position not being filled from the community health teams through the blueprint? How does this position in this one practice differ from what a master's level licensed clinical social worker who's funded through the blueprint, who should be embedded in family practice? How does this position differ from what that position is?
I think they would have to answer the question of why. I think from our perspective, it's a capacity issue and that the work is divided because the social workers in the program can't do everything that our program does. Their program is basically office-based, ours is community-based. So our person is at school meetings, is at DCF meetings, is getting kids to therapy appointments and whatever. They're going to families, going to in their home visits. It's a different type of service.
Oh, yeah, go ahead.
Can you bill Medicaid for that?
For the services that position provides.
Yes.
That's all through our EPSDT funding.
I don't know what that is, but is it Medicaid billable?
Some of those services are potentially billable under Medicaid. For us, it would fall under the mental health case rate. So we're capped on those dollars in total. And so this particular position and what they're providing is supported by $78,000 of this EPSDT funding. So could some of those services count under our other funding? Potentially, but there then wouldn't be the $78,000 to support that position because we're capped on what those resources are for our mental health case rate.
Nicole, is that service Medicaid billable?
I think I would agree with what Sandy said, which is that some of those services would likely be billable. And I would just say every organization is capped in the sense of like you have a budget for the year, but if your service utilization and your caseload far exceeded your budget, like any other service, Medicaid would go to budget adjustment and say, we need to ask for additional money to fund service utilization increases that were not anticipated with the budget when it was set.
Okay, that's helpful.
Can you explain to us what EPSDT is?
Sure. Early periodic screening, diagnosis, and treatment. Wanting to catch these families and kids earlier, trying to make sure they're getting connected to Medicaid, dental homes, being successful in school, getting families connected to services if they don't need them. So it's really trying to move away from a crisis model. And my understanding was it was cited as a duplication of services. So I apologize if that's not how you heard it. I'll talk about community outreach too and why that is considered a duplication.
Just to build on this EPSDT administrative Medicaid, I think about it, and this might not be accurate, but I think about it as an old funding stream. It is something that made sense 24 years ago when it was brought online. It had a 50% federal participation rate. I don't know if that's still true or not, but it was beneficial to bring it in, and it funded a certain piece of work, and it has remained there. Different organizations, DAs throughout their time advocating for different funding models or pilots, whether it's IFS or just different things that have come along, have gotten infusions of different types of money. Some of those dollars, when the system went to case rate, got rolled into the mental health case rate that organizations got. This was left carved out at the time because it still had that beneficial match rate. And so could it be part of the case rate? Probably, if there were additional resources in the case rate to support that position. And the clarification that I learned after listening to last week's testimony and learning about the embedded position cut is that there is additional EPSDT funding that supports not only that position, but 5 crisis clinicians in first call, which again is similar work to what's happening under the case rate, but there's this historical piece of funding that didn't quite fit in the box. So I don't know if that helps or made it worse. But,
How long has the position been in existence for?
I think it's been 24 years. The embedded position in particular, the admin Medicaid has been about that
This
length of
one
time.
position that we're talking about, how many?
That one. I believe it's 24 years.
So I would say we're not in a pilot anymore. It's no longer a pilot. So I'm wondering, it's one position in one practice, which I might add is a hospital-owned practice as well. Do we have data on the quality or outcomes of this one practice compared to all others? And if it's been a successful position, why have we not extended it to every other practice? I guess
It's challenging to answer for the other organizations. I think other DAs have had iterations of this position that get funded in different ways. The administrative Medicaid cut that's being proposed is the embedded position and the money that supports 5 crisis clinicians. So I don't want to lose that in the conversation. We've thought about, could it be funded by Blueprint? We have other positions that are funded by Blueprint that could be explored. This particular one, or does it really fit with us and how it is? We also received a memo last week from the Department of Health mentioning that the embedded positions, we have 2 others that are not in the primary care that are funded by Blueprint. Those are not in the governor's budget for the coming year. And so we're questioning the viability of what we currently have in those other positions. And it puts a bigger question mark on, is that a way to fund or retain this particular position?
I just want to say, I also have concerns with the fact that it was explained to us that it was embedded in pediatric practices. And while I do realize that family medicine has a large contingent of pediatrics, this is not serving a pediatric practice where 100% of their patient volume is under the age of 18 or 21. Anyways, Leslie, you have a question?
Question for Nicole, but I'm not sure if you would like it or if you want.
I'll take it.
I don't know, meaning, I didn't know if you'd like it now. Is what I was going with that.
Do you want to, how about you write it down and then at the end,
I'll remember.
okay.
Yeah.
All right. I'm sorry, Daisy.
What was the dollar amount for this position?
78,304.
Thank you.
All right, I'm sorry. I diverged from the whole. I do realize that there are other positions in this, so if you wanted to talk about those as well.
How about we move to community outreach now? There was some interest in that. So I think you all heard the proposed cut for the community outreach team is $160,000. We are in 9 communities throughout Chittenden County. This is different than our street outreach program, which covers Burlington. We're talking about the extended area. We are closely connected to the local police departments and the town managers. That group is our cohort that connects to our team. This is a group, this is a service that was put together based on a street outreach model to connect with people that often are on the fringes of treatment, that don't want to come in, that don't want to sit through an assessment, opening paperwork, releases of information. This is a mobile team that goes out to our communities to serve highly acute crisis. Someone is actively suicidal and has a weapon in their hand, very significant psychiatric symptoms like psychosis, and somebody else who might just be in the community sitting on a sidewalk crying and clearly in need of support. So it's really a full range of services. The intention of this group is to work collaboratively with police so that when they are needed for safety reasons, they are there with us. And when they are not needed, to please excuse them and let them move along to do the other important work that they have to do. So the partnership and the relationship that develops between the teams is very crucial. We also provide lots of follow-ups, surveying areas that are of high impact, right? It might be strip malls, it might be the University Mall. We go through different areas to try to foresee problems that might exist, as well as respond to calls. I just want to clarify, I can assure you, our staff is not sitting around in an office all day long. They are very, very busy and try to do as much preventative work as they can. At times, our community outreach folks need to call the first call team for enhanced mobile crisis if it is a higher level of care evaluation, an emergency exam evaluation, which is what is our involuntary care. So the connection between our teams and the whole array of crisis services is really important. And the continuum, I think, is what makes us really viable in responding to the nuanced needs of people as well as the bigger system. So I'm not downplaying any part of it, but they are different and distinct. And I do not see community outreach as a duplication of services. Folks will not necessarily call 988. I'm not against 988. I think it's fantastic. I think many people in our community would like sort of the anonymity of that and maybe having some more privacy. I think other people need the knowledge and the trust in a well-established community mental health center like ours, and connection to the teams that they work in. Many of our community outreach workers have ongoing relationships with people and see them again and again and again. So maybe on the first visit, they're not agreeing to services. Maybe on the fourth one, they are. So it's a constant trying to engage people in services, keep people out of the emergency departments when we can, and decrease police intervention when we can.
Daisy and then Mara.
I just wanted to say that I deeply respect the years of evolving needs that you've witnessed through your time at Howard and all the people that you've seen receiving that care and those that you've seen, missed by it and seen lost around Chittenden County. And so I really respect your input on this program, that it is different. I think that's all.
All right.
And looking at on the first page, when bullet point, when you were talking about the elimination of the $160,000 grant, and it says shifting this expense to municipalities. When you say shifting this expense to municipalities, are you referring to mobile crisis units, or is it also shifting to municipalities that maybe don't have services in place to meet the needs that are now being left?
So we contract with the cities and towns for these services. And so they ask for this level of service. We have a total cost of it. That cost is reduced, has been offset by the grant that DMH has historically had. And so it's $160,000 less, but towns and municipalities are paying for this. It's not part of the core services that we provide. It is in addition to it, as Beth said, it's a different response. We're able to go out, assist on a call, maybe co-respond with a police officer or address something in the community where somebody's not asking for our help. They're not asking to be opened to the agency. They're not producing their Medicaid card. They're not asking for a diagnosis. It's a different model that is not when right now through our core work, if you will. And so this is something that we have partnered with, that towns and municipalities pay for. And so when we learned about this, we did learn about elimination of the community outreach grant a few months ago, with a suggestion that the street outreach grant in Burlington will probably follow in the subsequent year, that we've not heard anything more on that. But the team very early on got out to the towns and municipalities to be able to talk about, here's what's happening, here's the shift as you're building your budgets, and is this still a service that you can afford and that you want, or is there something else that we should be talking about? And also at the same time, making sure that people are clear that if you don't continue to contract for these services, that doesn't mean you can't access Howard Center. Here's what it looks like. Here's what's available under Enhanced Mobile Crisis. Here's what's available with the mental health urgent care. Here's what it would look like when you call us, which is different than having an assigned staff who is sort of part of their team, who knows all the officers, who shows up at roll call, who's out walking around proactively addressing things that are occurring out in the communities. And so that's what that mention is, because as they have indicated, they value the work, they want to maintain it. It is coming at a higher cost to them without this grant to help offset the
So they
expenses.
won't be left without services. They'll just have to pay more for them.
Correct.
So the financial burden would fall to municipalities that may or may not have the financial ability to pay for those services.
Correct. And we don't unfortunately have the financial wherewithal to be able to provide the services without the cost being covered, which is again, where it's a choice, right? For municipalities, where do they spend their dollars? Where don't they? And if they can't afford this package of services, but want something different, wanting to leave that door open, what might that look like, right? What else could we do in partnership? But again, needing to make sure as an organization that the services we're providing are appropriately funded, or we're not in the place to be able to provide them.
Like, just real quickly, can you remind, how much was it?
160,000.
160, so
Yeah.
we'd be asking 1, 2, 3, 4, 5, 6, 7, 8, 9 communities to make up 160,000. Have you received, I realize they're all building their budgets right now. Have you received responses from
They
any?
overwhelmingly support the community outreach program and don't want it to go away. And they're advocating with their own board, select boards right now around how they're going to cover that cost. And they knew, and we were very explicit about, if you don't choose this and you would prefer a different model, you still can call First Call, you still can access mental health urgent care, you can still call 988. And they were quite adamant about, I'm not calling 988 when I'm standing out in the woods with a person. And again, that's not a hit on 988, but these municipalities really value the ongoing relationship and what we've been providing for them.
And I'll just say, I represent one of those communities, and I meet with our chief of police once every year. And the one thing he says is if he could hire his own just strictly Essex group, he would do that.
Several of our towns have reported that to us and asked, how can we do it? We wish we could, we can't fund it.
Anyway, Daisy, I'm sorry.
I was just gonna say what you said, and I think I said it last time when we had DMH in here, is just the value of this program has been lifted up by every one of my municipal leaders. And, they're advocating to me for keeping it. And they shared with me a chart of the percentage of the 160 that each of the 9 municipalities would be charged based on their historic usage of the services. So I can share that with the committee if you're interested. So the value of the program is not in question. I don't think by any means. It's one of the most impactful things because, as you noted, Sandy, it's one of the most low barrier services we have for communities.
I think if you have the opportunity to read what we submitted in writing, hopefully the takeaway will be that, the shift towards the state's vision for crisis and particularly enhanced mobile crisis is really important as we think about, as a state, how do we make sure everybody has at least some level of core services? And I believe there's portions of the state that didn't have a 24/7 crisis response. And so how do we make sure, right, that everybody has something, but also balancing that with how do we not assume a one size fits all is going to fill the needs in every community? And how do we at least have our eyes wide open if there are going to be trade-offs or if there are things that are going to be an additional cost, if you will, right, to be able to do this over here and have this one size fits all. But that means that some very established, very impactful programs and responses in local communities will no longer be there. So I think it is just sort of having our eyes wide open and hopefully being able to strike that balance between making sure everybody's got a certain level of core services while also having the ability to be able to respond to their unique communities' needs and pressures in partnership with their communities.
And I do think, just to follow up, that yes, not one size fits all, but also that there's a lot of value to the 988 and, centralize the need for or centralized calling, right? And I just think now is not the time. Like if there is a transition, it should not be immediate in terms of having folks go through that door. I'm hearing that, were we to use 988 for something like community outreach, that the response I was quoted was like 1 hour. I'm not sure that's accurate with the community members I've spoken with, but if we get a response time and no barriers that matches what you're able to deliver through your program, great. I'd be happy to have people call 988, but until we're there with mobile response, I'm just not sure that, were I in crisis, I'd want folks to go through that route quite yet. They'll get there though.
There's a lot at stake. And I think as we do make these shifts in the service delivery model, how do we do so very carefully and very thoughtfully? And certainly as we think about enhanced mobile crisis and our current first call for Chittenden County program, there's opportunity there to be able to respond under that model. With that shift, with a two-person response, it requires more staffing, it requires more training, it requires more resource, and it actually pays less. And so how do we do that in a thoughtful, meaningful way, maintaining the staff that we have, testing out what are those response times? What does that look like? When might it make sense for a direct call versus something through the 988? Is it really a one size fits all? Maybe it is. And 2 years from now, we'll be shifted and say, oh, well, that was really successful. We don't need any other model. But I think it is exactly as you're saying, Representative, how do we test that?
Wendy, just a quick question. We were talking to our town manager, I'm from Colchester, who we're looking for some sort of compensation because we have a couple of hotels that get a bulk of calls, and we were looking at from pre-pandemic, and no one's putting down, we're happy to take these patients, but the amount of money that is spent on these emergency calls, and he was saying it's a handful of people, but the amount of time, and he said, I don't really want to be compensated for this. I would just like to have somebody there. And I don't know if that's.
Do you mean like an embedded position in a hotel?
Yeah. As opposed. What's that?
French.
Well,
It's a
hotel.
I don't know.
It's a hotel.
Yeah.
But he just said it could easily be handled that way, but instead we're sending out EMS, we're sending out our police calls. It's gone from 4 a month to 4,000 a month. It's expensive. That's it. That's all I had to say.
May I comment? Are we out of time?
Oh, and then I think Woody had a question.
I'm just looking.
Oh, Brian, I'm sorry, I didn't see you. Woody first.
Thank you. I just wanted to quickly say, as a person.
Go ahead.
Oh, I'm sorry. I thought I heard you call on me.
Go ahead. Thank you.
That as a person, I know I'm not a witness, but as a person who actually is doing this work as a crisis clinician, as I digested the testimony from DMH, I've come to the conclusion that it just aligns with what others are saying, that this would be a cut to a cut of services. It would be a cut in the system of care at a time when the demand is higher than ever. And I think if we cut this program, it's only going to shift the burden onto law enforcement and the criminal justice system and the healthcare system in other more expensive ways. And so it's an example of a cut that would cost more than the savings of the cut. And I couldn't in good conscience support it for that reason, as well as the impact it's going to have on people who fall through the cracks and suffer needlessly because they're not able to access the system of care in other ways, as well as their neighbors who are impacted by the behavior of people who are struggling. So I just wanted to say that. Thanks.
Thank you, Brian. Woody?
Yes, I'll just get to the point. Am I correct in that you're asking for approximately $1.2 million to continue the program?
I think it was that much. I think it was.
It's 600,000 overall that's being proposed to be reduced.
That's all you want.
Might be 600,000 change.
655 is your request.
Yes. And that is to keep those crisis clinicians intact, as well as community outreach. I don't want to lose those. And that leads me into, I'm sorry?
No, go ahead.
Vermont Enhanced Mobile Crisis. I just want to clarify with everybody, it is one team. It's not like there's a set of people to do first call. There's a set of people to do. We have one team that do multiple jobs. Mobile crisis is a great thing. It's a best practice. It's a 2-person response. We are introducing the peer model peer support services. So folks with lived experience can be helpful in a crisis situation. It's a lot of training. It's a good 25 hours additional training. We have to pull staff from the field to get all their training in. I appreciated what you said, Daisy. We want the system to evolve. The speed at which we're being asked to evolve the system is quite aspirational. Some would say aggressive. When you have longstanding embedded teams, we're still dealing with COVID, norovirus, flu. We're still dealing with very low staffing as Amy shifted. So we're trying to pull this off, and we were trying to stand up mobile crisis. At the same time, we were developing a mental health urgent care facility. So I'm not whining and complaining. I want it all. I want us to do all of it, but there has to be some perspective on what's happening on the ground for us to pull these off successfully and for us to stand by them. And I'm really concerned that if we diminish our crisis team by 5, we have some other concerns about some other funding dropping off. That's going to reduce capacity. And we're going to get back to where we were, that people are waiting in EDs for hours. We're not going to be able to get there. There's going to be a queue of people who need all these services. And reducing our staff, I think, is one of the worst things we can do right now. And we can't fund them without this money.
So just to clarify, the reduction that is proposed would reduce your your staff of 8, or sorry, your team of 8 down to 3 people.
Not sure where you're seeing staff of 8.
I thought you said that. I was wrong. How many?
It would reduce our crisis team by about 19%.
Okay, so how many are on it now?
So it's, I believe it's 22.5 FTEs.
That's what it's 28.5 if you combine the crisis clinicians, peer specialists, and care coordinators. It's on page 3 of what we provided. So there's 22.5 crisis clinicians, 2 peers, and 2 care coordinators. So reducing 5 of those is 19% of the current staffing.
Okay, that's a whole 5 out of 28.
Yes.
Any other questions?
I say one more thing.
Sure, of course.
I think what we're really trying to achieve in our state for a standardized crisis service, I think we want equity. I don't think we're shooting for equality. And my fear is with these pushes of a system change, it's about making sure it's the same everywhere when the communities aren't the same everywhere. We want equity. We want everybody to have access, but we want communities to have what they need. Our multicultural liaisons are a great example. That funding got cut. And Burlington and Winooski have the 2 largest refugee populations that exist. We had to figure out how we're going to keep those multicultural liaisons going on, because they're the ones who are making a difference in those communities. Thank you for listening.
Thank you. Thanks for coming in. And hold on one second, Leslie.
Not for you guys. Just before you went off live.
Okay.
As I said earlier, I had a question for Nicole, but I guess she had to leave.
Oh, yeah.
But I'd just like to get my question on the table.
Okay.
It really just seems that there's been a real focus, a microscope, on your budget and cuts there. And I was wondering if that was applied across the whole system, and how they thought that through. So that's my curiosity of looking at it from a systemic point of view.
It's a great question.
Great question. And we can ask.
Well, it's on the record. I'm hoping someone.
Maybe they can get back to us.
Yes, I'm hoping. I'm sure